Hello everyone, my name is Professor Galia Spector. I'm from Rabin Medical Center in Israel, and joining me is Dr. Anat Rabinovich from Soroka Medical Center, also in Israel. We are the representative of the Middle East in this project about TTP. As a matter of fact, we are not that convinced that we can represent all countries in the Middle East, since the public health standards of care may be different in each country. In Israel, all citizens have basic life insurance, which covers hospitalization and also a wide variety of treatments, including expensive treatments like caplacizumab for TTP. Therefore, I believe that the standards of care in Israel are very much similar to those of European countries. We'll start with you, Anat. Can you please summarize briefly on the pathogenesis with TTP?
Yes. So thrombotic thrombocytopenic purpura, TTP, is a thrombotic microangiopathy characterized by microangiopathic hemolytic anemia, thrombocytopenia, and ischemic end organ damage, resulting from formation of platelet-rich thrombi in the microvasculature. TTP is caused by deficiency of the ADAMTS13 protease, which cleaves ultra-large von Willebrand factor multimers on the endothelial surface. The ultra-large von Willebrand factor multimers that accumulate are thought to be responsible for causing the thrombotic microangiopathy. ADAMTS13 deficiency results from the formation of autoantibodies in immune TTP or from mutations in the ADAMTS13 gene in congenital TTP. Galia, let's turn to you. Do we have regional data regarding prevalence and outcomes of our patients?
Israel, as you know, is a very small country. It's only 400 kilometers from north to south and 100 kilometers from east to west. In this small area, we have 12 hospitals that can perform a plasma exchange and therefore treat ITTP patients. And the other hospitals, it's about 10 hospitals, they transfer ITTP patients to the other hospitals with a plasma exchange capability. This should usually take a less than 2-hour drive in Israel. Unfortunately, we don't have a registry for TTP in Israel, so we don't have exact numbers and outcome data for our patients. However, 3 years ago, we conducted a survey and estimated approximately 28 TTP patients per year. The population in Israel nowadays is around 9 million people. So this translates to approximately 3 patients per 1 million per year. And since the known current prevalence for TTP is between 2 to 4 cases per million each year, so I believe that the rate of underdiagnosis in Israel is very low, if any.
So there's not much underdiagnosis of TTP. Do you think there may be any big delays in diagnosis?
The greatest delay perhaps could be at the beginning. As we all know, the initial signs and symptoms of TTP are not specific. The patient can usually report on several days that he hasn't felt good, symptoms like general malaise or abdominal pain, which are not specific. So there might be a delay in self-referral to primary care or a delay in referral for blood test. However, once bleeding symptoms or neurological signs appear, or if a blood count is performed and showing thrombocytopenia, the patient will be referred to the hospital. In my experience, there are usually no big delays once the patient arrives to the hospital. In my hospital, for example, in any case of newly diagnosed thrombocytopenia, the lab will automatically look on the blood smear and report on the presence of schistocytes. We have hematologists on call 24 hours, and the ER doctor will generally call the hematologist, who will, in most cases, rapidly make the diagnosis. Anat, maybe as a hematologist on call, can you please describe how we make a clinical diagnosis of TTP?
Okay, so when a patient comes into the emergency room with those non-specific symptoms and thrombocytopenia, as you said, a blood smear should be performed. And in my hospital as well, blood smear is automatically performed on every blood count with thrombocytopenia. First, to rule out pseudo-thrombocytopenia, and second, to look for and give a schistocyte count. A count of 2 or more schistocytes per high power field, and usually more than 1% of all RBC in TMA, and even higher in TTP is considered positive. Rarely, however, a patient with early TTP may not have schistocytes at all. And it is crucial to involve a hematologist if available at this early stage. Other lab tests for evidence of microangiopathic hemolytic anemia should be sent out, like bilirubin, LDH, haptoglobin, and additionally a creatinine level, coagulation panel, and a direct Coombs test, which will aid in distinguishing between primary TMA syndromes and other systemic disorders. So once we suspect a primary TMA syndrome, the next stage would be to decide whether the patient needs immediate plasma exchange. And this is the problem. Distinction of TTP from other TMA syndromes is not always easy because of the overlapping clinical manifestations. Measurement of ADAMTS13 activity less than 10% will confirm the diagnosis, but results may not be available rapidly enough to guide initial management decisions. And it is therefore crucial for the clinician to identify patients most likely to benefit from plasma exchange based just on those immediately available data.
So what are some of the other possible causes of TMA, and how do you rule them in or out?
Other causes of TMA are often revealed by a focused history, physical examination, and lab evaluation. For example, if we see prolonged PT, PTT, and low fibrinogen, that would focus us more on DIC. And a very elevated creatinine is seen more in hemolytic uremic syndrome. So we then follow the ISTH guideline and incorporate the clinical features and initial lab tests into the plasmic score. The plasmic score is devised to predict the likelihood of ADAMTS13 activity less than 10%, meaning it's devised to help us estimate the pretest probability and support the diagnosis of TTP. While this score cannot substitute for clinical judgment and cannot be used to definitely confirm or exclude the diagnosis of TTP, it may be helpful for guiding the decision of whether to initiate therapy. In our center, all patients with a plasmic score of 5 or higher are empirically treated. So to get to this stage, to the point where it is pretty clear that plasma exchange and steroids need to be started urgently, does not actually require many resources, just a very organized thought process and a high level of alertness. And this could be achieved by educating the staff in the emergency room. Galia, so if ADAMTS13 activity level is not available, how are clinicians handling this critical step? What needs to be done to ensure appropriate diagnosis for our patients?
In Israel, not all hospitals perform ADAMTS13 testing, so we begin plasma exchange before results of the assay. In Israel, ADAMTS13 is performed by ELISA testing, and it's available for us in my hospital every weekday, not on weekends. Hospitals that do not perform ADAMTS13 assays will start plasma exchange and send the test to another hospital. Results should be obtained in a few days, definitely less than 7 days or 1 week. The ELISA test that we do provides results for both ADAMTS13 activity and antibodies. And it's a bit time consuming. It takes about 4 hours to obtain results. I'm aware that there are other rapid tests available. For example, the Tectostream ADAMTS13 activity assay takes no more than 30 minutes. However, this test is semi-quantitative and may not give numerical results. The other test is Hemosil AccuStar ADAM13 activity. This test is done with a dedicated machine, and it can provide results in 1 hour. The machine is currently being tested in one of the large hospitals in Israel at the moment. A good rapid test may guide prompt initial treatment as well as a timely decision later on to stop caplacizumab treatment. I think this is an unmet need in Israel to be able to provide rapid results of the ADAM13 assay. Anat, you have a unique experience in your hospital with patients with congenital TTP. Can you please expand on how you make the diagnosis of congenital TTP?
Yes, so congenital TTP represents less than 5% of all TTP cases. The prevalence is 1 patient per 1 million. More than 200 mutations in ADAMTS13 gene have been described, and these are cataloged by the Hereditary TTP Registry, which has enrolled over 140 patients from 17 countries. The deficiency is only severe enough in homozygotes to lead to the clinical syndrome. When should you suspect congenital TTP? So the suspicion for congenital TTP should arise when there is a positive family history, onset during childhood or pregnancy, multiple recurrent episodes, absence of ADAMTS13 antibody, or persistence of severe ADAMTS13 deficiency in an asymptomatic patient. And in these cases, testing for mutations in the ADAMTS13 gene is appropriate and available at no charge through the Hereditary TTP Registry, and the link for the registry is provided below. Pregnancy can trigger acute episodes in congenital TTP patients who were previously asymptomatic, and approximately 25 to 30% of all obstetrical TTP cases are actually due to congenital TTP and not immune TTP. So a very high level of suspicion for congenital TTP is warranted specifically in pregnant patients. The prevalence of congenital TTP may be higher than estimated, at least in our region of the world. Since congenital TTP is autosomal recessive with a rare gene frequency, some affected families may have a history of consanguinity, and the prevalence may be greater in populations in which consanguinity is common. So let's talk about our cohort a bit. So Soroka University Medical Center, where I work, is the only tertiary care center in southern Israel, covering a population of 1.2 million people. Among them, 20% belong to the Bedouin Arab community, in which consanguinity is common. So patients in our cohort were identified through episodes of microangiopathic hemolytic anemia and thrombocytopenia, absent ADAMTS13 activity, and no antibody. And since we noticed familial aggregation of cases, patients were referred for DNA testing. We identified a novel mutation on chromosome 9 that is found within the cube1 domain of ADAMTS13. And so far we recognized 21 homozygous patients that belong to 2 closely related families of Arab Bedouin descent. The cohort consists of 19 females and 3 male patients, whose age at initial presentation ranges from 14 to 44 years. In our cohort, presenting symptoms of congenital TTP were mainly during pregnancy. Out of the 19 women in our cohort, 16 were diagnosed following a pregnancy with obstetrical complications and had a very heterogeneous clinical presentation and course. Presenting symptoms of congenital TTP during pregnancy included recurrent pregnancy loss, stillbirth, early onset preeclampsia, HELLP syndrome, IUGR, and preterm premature rupture of membranes, and the total perinatal mortality was 30.7% before diagnosis. We actually collected 28 placentas. All of the placentas have lesions consistent with maternal underperfusion, suggesting that the underlying mechanism leading to the clinical presentation was actually vascular disease of the placenta. Out of the males, one of three male patients presented with Budd-Chiari syndrome. One had a stroke, and one was diagnosed following asymptomatic thrombocytopenia investigation. And this is one of the largest congenital TTP cohorts in the literature, and unique due to the fact that all patients are homozygous for the same mutation. Another important point in congenital TTP that I need to emphasize is the lack of genotype-phenotype correlation. Despite the fact that all our patients come from closely related families and actually bear the same mutation, their clinical presentation is highly heterogeneous. And in addition, our data suggests a discrepancy between ADAMTS13 activity level and severity of clinical presentation. Results from our group and others support an assumption that phenotype severity cannot be attributed to ADAMTS13 deficiency alone, and that other environmental and hereditary modifiers may influence disease course. And it is also plausible that some yet unknown modulatory genes or conformational changes in ADAMTS13 may affect ADAMTS13 activity. And I invite you to read our publications on this cohort that are linked here.
Thank you very much, Anat. It was very interesting. Thank you for joining me on this first episode about prevalence, outcomes, and diagnostic challenges of TTP. Please join us also for the episode 2, during which we will discuss current therapy and recent developments in the treatment of TTP.